I'd like to welcome everybody to the weight loss surgery seminar here at Jenny Stewart Health. My name is Gerame. I'm the bariatric surgeon here at Jenny Stewart. This slide shows some other members of our team, including Misty Cook, the nurse practitioner of the program, Storm Newsom, who's the bariatric coordinator, and Christian Shaw, who is our registered dietitian. The reason we're even talking about obesity surgery is because it is a growing problem in America despite all of the medical and surgical treatments out there. This slide shows some of the reasons for the prevalence. Around the 80s is when TV shows started changing as well as technology. We no longer had to get off of the couch in order to change the channel. We see another spike also in the late 2000s when the mobile devices started booming, and we see despite all of our surgical options out there, the prevalence of obesity is continuing to rise. It is not just because of that. There are also genetic factors as well as behavioral factors. All of these work together to cause this obesity epidemic. Obesity is linked to several serious conditions. The most common that we see when we're talking about weight loss surgery is type 2 diabetes, sleep apnea, and hypertension. How do we measure obesity? The scale that we've used for many years is not perfect, but it's the BMI. It takes our weight in relationship to our height and it spits out a number. It is not perfect because it does not distinguish fatty tissue from muscle. The guy on the right of the screen would also have an extremely high BMI. In recent years, there are discussions about switching to a different type of index, such as the waist to hip ratio or the waist to height ratio, which would give us better indexes for obesity. This slide shows different BMI categories. The patients who are candidates for weight loss surgery are in the last two right categories, in the BMI to 35 and up range. As of May of 2022, the CDC states that nearly 40% of Americans qualify for weight loss surgery in these last two categories, and this number continues to rise. This is a map from the CDC showing state by state who has the highest BMI category, and Kentucky is usually in the top 5. The reason we're interested in weight loss surgery is we know the higher the BMI goes up, the risk of dropping dead goes up exponentially. And so we are trying to help with this problem. I like this graph because it also shows that if your BMI gets too low, your risk of mortality also increases. We're looking for that green, that area in the light blue on this slide, which is what we call the green zone of the BMI. In recent years, there is a boom of weight loss surgery medications. This is a new big pharma push. And there are many, many patients out there on these medications. These are lists of some of those GLP-1 medications. What we know about these medications is they act like a hormone that tells us that we are full sooner than we actually are. Some of the most common names of these medications are Ozempic, Wegovy, and Mounjaro. They also promote the release of insulin in the pancreas, which lowers our blood sugar levels. They slow the emptying of our stomach so that we stay full longer, and they suppress hunger cravings. They will allow you to lose a significant amount of weight. What we've seen since they've really started hitting the market is patients will lose weight for a little while, but the drugs either become expensive or patients don't like the side effects. And if you do stop the medication, you will gain the weight back. They are not perfect. They can cause nausea, vomiting, also other GI complications. They can cause more serious complications that are listed on this screen. This is a recent article from General Surgery News that shows after many years of research comparing them to placebo and comparing them to weight loss surgery, surgery seems to do better long-term in the amount of weight that you lose and keeping the weight off. The rest of the time we will be talking about weight loss surgery. There are two different categories of weight loss surgery that are available. One of them restricts the amount that you can consume, and the other one also restricts the amount that your body will absorb. We will hit on most of these. Who's getting what? For many years, the gold standard of weight loss surgery has been Roux-en-Y gastric bypass. Around 2010, the sleeve gastrectomy hit the market, and now it is by far the most common weight loss surgery that is being performed. The requirements for weight loss surgery are constantly changing. Some of this is bariatric program driven, and some of it is insurance driven. This slide lists the things that are required in order to get to the operating room for weight loss surgery. They include a letter from the primary care provider, a psychological evaluation, pulmonary and cardiac clearance, consecutive dietitian visits, a nutrition class, a class with the bariatric coordinator, and several weight checks. Weight loss surgery is not perfect. Just having the surgery will not magically make you lose weight. If you return to your old habits, you will gain the weight back. Success with weight loss surgery requires appropriate food choices, appropriate attitude about the surgery itself, changing your habits and your tradition, and getting more active. As with any surgery, weight loss surgery has risks associated with it that are listed on this screen. The three big ones that I mentioned to all patients are staple line leak when we're talking about sleeve gastrectomy, lower extremity deep vein thrombosis, and pneumonia. A few words about laparoscopic gastric bypass. It is the gold standard weight loss surgery. It has been done for many years. It is a safe surgery. There are multiple steps to the surgery, including rerouting the intestine and creating a small pouch in the stomach to limit the amount of food that can be eaten. Some of the side effects that we worry about include connection leaks, vitamin deficiencies, ulcers at these connections, and dumping syndrome, which causes flushing, abdominal pain, and sometimes diarrhea after certain foods are eaten. It is a very difficult surgery to reverse if there are any needs for this. It takes a little bit longer to get over the surgery when compared to some of the other weight loss surgeries out there, but it has very good weight loss success. A newer surgery that has started being performed recently is what we call the mini bypass. Others call it the single anastomosis gastric bypass, the omega loop gastric bypass, or the one anastomosis gastric bypass. It is essentially a sleeve gastrectomy and a gastric bypass combined. There's less time in the operating room because there's only one connection between the stomach and the intestine instead of two with the Roux-en-Y gastric bypass. It has very good weight loss success. Some patients may experience heartburn and may experience dumping syndrome from this surgery. It has very good weight loss success. One of the bigger surgeries that's out there is called the biliopancreatic diversion with duodenal switch. This surgery is also done laparoscopically. It has a very good cure rate for diabetes mellitus type 2. It also has less complications of dumping syndrome, but because it is a bigger surgery, it has more potential risks in and around the time of surgery. Lap band was done for many years in the United States. It has recently fallen off of the map. The device was placed just below the diaphragm at the GE junction. When the device was tightened, it caused patients to feel full. What we found in recent years is patients had difficulty figuring out the difference between food getting stuck and feeling full. If too much fluid was added to the band, it caused vomiting and abdominal pain. If this continued, fluid had to be removed from the lap band device, and then they lost that restriction and were able to eat again. Two of the complications that are being dealt with after the device is placed are prolapse or slippage, which is the upper right cartoon, where the device actually slips down lower on the stomach and it causes a pouch above the band. This can lead to nausea, vomiting, and food intolerance. We also are concerned about erosion, where the device wears through the wall of the stomach, which is depicted on the bottom right cartoon. If erosion happens, the lap band device needs to be removed. The key to success with lap band were strict follow-ups, and patients just became very dissatisfied with this procedure. The laparoscopic vertical sleeve gastrectomy is, as mentioned earlier, the most popular weight loss surgery out there. It focuses on one organ, the stomach. The cartoon on the right shows that the majority of the stomach is removed. About 85 to 90% of the stomach is removed. You have a long staple line remaining on the stomach. The stomach tissue immediately starts growing over this staple line and sealing it. The stomach becomes a tube shape. It has very good weight loss success, especially over the first year. The other way that the sleeve gastrectomy works is some of the hormones that are made in the stomach that send signals to our brain telling us we're hungry are no longer present when that portion of the stomach is removed, so there's less hunger. If you have been told you have a hiatal hernia, this slide depicts what that is. When the esophagus crosses the diaphragm on the top picture, it becomes stomach below the diaphragm. On the bottom picture, a portion of the stomach is up above the diaphragm. That portion that is above the diaphragm is called a hiatal hernia. This is important because we need to ensure that all of the stomach is below the diaphragm before the stapling is performed for a sleeve gastrectomy. So if you have a medium to large sized hiatal hernia, at the time of sleeve gastrectomy, this will be fixed before the sleeve gastrectomy is completed. As with all the other weight loss surgeries, sleeve gastrectomy also has risks associated with it. It is a very safe surgery, but some of the risks are listed here, including vitamin deficiencies. We do have patients on vitamin supplements following the surgery. Patients also may have symptoms of nausea, vomiting, and dehydration. One of the things that we worry about the most is a staple line leak, even though this risk is very low. If a staple line leak were to happen, there are multiple procedures that have to be done in order to get this to heal. If patients experience reflux disease, this may worsen after sleeve gastrectomy because of the reconstruction of the size and shape of the stomach. It may allow acid to reflux into the esophagus. If patients overeat following sleeve gastrectomy, they can stretch their stomach back out and be able to eat larger portions in the future. This is the code that you need to give to the bariatric coordinator when you talk to her about your interest in weight loss surgery. So write this down. She will be asking you what the code is, and this is the code you need to tell her. After sleeve gastrectomy surgery, you do go to the recovery room just like any other patient who's undergoing general anesthesia. You are admitted to the hospital at least overnight, but sometimes for 2 days. Once you start awakening from general anesthesia on the day of surgery, you will get up and walk immediately. Once the anesthesia has cleared and you are feeling a little better, on the night of surgery, you will be started on non-carbonated clear liquids. If a drain is placed at the time of surgery, this does not mean anything bad has happened, but that drain just allows us to look at the fluid that's accumulating at the staple line. When you are discharged from the hospital, you are on a strict postoperative diet. Will things get stuck if I have sleeve gastrectomy? Absolutely. The texture of some of the meats that we're used to eating in America, no matter how you cook them, they get stuck. Chicken is very common, as well as yeast rolls and other meats such as pork chops and pot roast. You have to be very careful with these. What are the strict guidelines after surgery? We have a strict postoperative diet. On the week you go home following surgery, you are on non-carbonated clear liquids. It's all about staying hydrated when you go home. A week after this diet, if you are feeling a little better, it gets advanced to full liquids, then puree diet for a week, and then soft solid diet for a week. And then on the 5th week, you are finally back to small portions of solid food. As mentioned earlier, there are vitamin supplements that you will also be taking. The key to success with weight loss surgery, any of the surgeries out there, include follow-ups where you talk to myself or the nurse practitioner, you talk to the coordinator, and you talk to the dietitian. Periodically, labs will also be checked. Other keys to weight loss success: take small bites of healthy food, chew those bites thoroughly before swallowing them, wait 1 minute before taking another bite, drink lots of water, stop eating after 20 minutes or when you get the full feeling. If you have a choice, and you do have a choice, choose high protein foods. As you start feeling better after the surgery, increasing your physical activities, and then getting into an exercise program. There are also some new endeavors that are coming down the pike that will help us with revision surgery, and some of them are on the forefront of procedures for weight loss surgery. This is a picture showing endoscopic sleeve gastroplasty, which is actually a procedure that's done from the inside of the stomach during endoscopy. What problems improve after weight loss surgery? I'll leave this slide up for a minute. Pretty much every organ system is affected by obesity, and every organ system will improve following weight loss surgery. The only exception may be reflux disease that may worsen for a little while immediately after sleeve gastrectomy, but as you continue to lose weight, it will also improve. So why do we do weight loss surgery? To help people live a longer life and get rid of the majority of these comorbid conditions. This is another slide depicting improvement of these medical conditions, except gastroesophageal reflux disease / heartburn, which may get worse following sleeve gastrectomy. This is a slide showing some of our own data. We've done over 1,250 weight loss surgery cases since we began bariatrics in 2010. We've done over 680 sleeve gastrectomies since 2016. When you look at the national average of staple line leaks, we are right at the national average. What is the criteria for weight loss surgery? You need to be battling obesity with a BMI greater than 40 or a BMI of greater than 35 with comorbid conditions. You need to have documentation that you've tried other weight loss methods in the past and they have failed. You need to be an adult. No prior stomach or anti-reflux surgery, and an acceptable operative risk. What is the next step on this journey? You've almost completed the first step, which is attending the seminar. We also need to make sure that your insurance covers weight loss surgery. You will be enrolled in a nutrition class. There will need to be documentation from your primary care provider. We also have you undergo a psychological evaluation, cardiac and pulmonary clearance, an upper scope looking at the anatomy of your stomach, a swallow study looking at the function of your esophagus and stomach, and an initial consultation with me in the office. Once that is set and we've picked a day, we have you see the PAT team, which makes sure there's no abnormalities in your labs, make sure your EKG and chest x-ray are appropriate, and we have you meet one of the anesthesia team members. We also put you on a preoperative 2-week high protein, low carbohydrate, low calorie diet. The premier protein shakes are pictured here. We have you drink these shakes 3 times a day or Ensure Max protein shakes 3 times a day with some very select non-cooked vegetables and nothing else. You can also have all the water you want with Crystal Light. This preoperative diet is for 2 reasons. It gets you mentally prepared for the changes that are going to happen following weight loss surgery because you are not going to be able to eat as much as you used to. And it also helps use up some of the stored fatty tissue in your liver. And by shrinking your liver, it gives more room in your abdomen at the time of surgery and makes it a safer surgery. What if your insurance doesn't cover weight loss surgery? There are some options that can be made available to you so that you can still have the surgery. An important postoperative entity to success with weight loss surgery is support groups. Storm, our coordinator, has these every month. They are at the hospital. They have hot topics. There's also a expanding cookbook where you talk about foods that are tolerated well and are high protein foods. And there's also a private Facebook group. The last word, you can't do this alone. You need support from the bariatric team and from other people who have undergone the surgery and from family and friends. You have to stay active. You've got to get in some type of exercise program and keep doing this. You have to avoid junk food. We call these slider foods, including candy, ice cream, potato chips, and even diet sodas. The problem with carbonation is it expands in your stomach and it will dilate a sleeve gastrectomy. And we want you to be well informed. We want you to check out social media. We want you to watch videos on YouTube. We want you to know about the other surgical options that are out there because sleeve gastrectomy may not be the right surgery. Write this number down. You will get to know this number very well. This is Storm, the bariatric coordinator's phone number, 632-4555, extension 2230. If she does not answer, please leave a message for any questions or concerns. Again, this is Storm's phone number. I thank you for your time and attention and hope to see you soon.